everybody. Welcome back to the TIMSA Leadership Podcast. My name is Eric Claus, and I have the honor to be able to be your host. In this episode, we are bringing you several conversations we had during our yearly TIMSA conference. I know you're going to enjoy it, and it's going to add value to you.
Chris Kelly, I'm fired up that you're with us today.
Happy to be here.
Yeah. You are the first attorney that we have on
Oh,
the
wow.
podcast.
Okay.
So let me give everybody just an idea of what we were able to do. So yesterday you presented a mock trial, and there was about 500 people in the room. And when the providers came out, everybody was talking about this. Like, this needs to be a presentation that everybody needs to hear. And just kind of tell us about you and what you do.
Sure. Yeah, I'm a healthcare attorney. I've been doing nothing but EMS-related healthcare law for almost 25 years now.
Wow.
So I've been pretty narrowly focused. Don't do a lot of liability issues, do more regulatory compliance issues. I boil it down to I fight insurance companies over money.
Yeah.
That's where I spend a good amount of my time. But, policies, procedures, making sure folks are doing the right thing, that's kind of what keeps me busy.
And you traveled a ways to get here. Where are you from?
Yeah, from South Florida, a little town called Punta Gorda. We're right north of Fort Myers.
Okay. That's
I
incredible.
lived in Nashville, though, for years. We were here for about 8 years. Born in Chattanooga, so have a lot of roots in Tennessee.
Yeah, that's awesome. Well, Chris, let's jump into it. One of the fears that we have as providers is, what if we get called to court? I've been there, not pleasant. Kind of tell us how we can stay out of trouble as EMS providers.
Sure. And, I think something you said about folks not knowing is key. And I'm happy that most folks haven't had the unfortunate opportunity to be involved in a trial. They're not fun. The depositions and the discovery to get there aren't fun. It's very stressful for a provider. But if we can show them how bad it can be and encourage them to do better documentation to prevent them from having that unfortunate opportunity, I think that's the goal. That was the goal of the class, is to understand that folks don't know what they don't know, and to give them a little insight into how really important is it that you follow your policies, that you have sound policies, that you keep your training up to date, that you track what you train, that you test on that training so that you can say that, it's not just a sticker for attendance, but I attended, I learned, and I can apply what I learned to my job. A lot of training falls short of those last two measures. So that was kind of embedded in the problems that came up during the trial. Okay. That was one of the things that I wanted to highlight for everyone, that when you have training but you don't really do it right, it doesn't really help you. Okay. Training needs to be accompanied by good information and some type of confirmation that folks really get it.
Okay. So let's talk about documentation. Let's say that you look at an EMS run sheet. What are some things that make you just sort of sink in your seat and say, this is not going to be good?
Yeah. And, there's two different audiences that I worry about.
Okay.
There's the regulatory compliance and payment folks, and then there's the civil or even criminal liability side. So luckily, we don't have to worry about the liability side. Occasionally, I'll run across a trip report, and I review hundreds every year. Okay. Usually what I see that makes me cringe is no patient signature on a Medicare transport. There's just no reason to not dot that I, but yet as an industry, it's something we still struggle with. And the auditors are onto that. They know, hey, if I can look for these few things, why read the entire PCR? If I don't see a patient signature, I'm done. I don't have to read the rest of it. I get to stamp it denied and move on to the next. So things like that make me cringe. Yeah. Not doing the small, easy things right. And then the narratives. Okay. I think some bad information, unfortunately, has been given out to the industry that, hey, if we've got all these check boxes, as long as you've got data in there, you're good. Those check boxes don't tell a story. Okay. not in a way that humans are wired to understand stories, right? We talk like you and I are talking.
Right.
We tell stories through words, not through drop-down menus. And when I see a narrative that says picked up patient, transported without incident, left in care facility, and that's the entire narrative,
Yes.
that makes me cringe.
Yeah.
Because if anything happens 2 days later to that patient, and we find out about it 6 months later, it's too late to add information. What did you do? All those pertinent negatives, right? I looked for this stuff. I didn't find it. That's still telling me something.
Yeah.
If you don't tell me that you looked and didn't find, I don't know. So that makes me cringe.
That's very powerful, and I hope everybody just kind of shares this because this is very, very important. Will you kind of share a little bit about the case that you all presented yesterday and really what the essence of that was?
Sure. When we first started looking at doing a mock trial, there was some talk about recent criminal cases in EMS. And I said, those are unicorns, luckily, right?
Okay.
Those are so rare. That is not something that we need to focus on.
Okay.
Focus on what we do day to day. Where can we really make a mistake that matters? And we focused on a intubation gone bad, right? Part of the facts dealt with a potential refusal, not assessing the situation correctly on the front end. Then we moved from that into a patient that was in distress and just wasn't treated properly, right? We violated some of our own policies. We violated some of the national set standards of practice of what's expected of EMTs and paramedics in similar circumstances. And then ultimately how those failures impacted the patient. What attorneys like to call proximate cause. Did it matter? Because we make mistakes. If the mistake doesn't change the outcome, then it's not something we have to worry about. But if that mistake is the cause ultimately of the further complication, or in this case, a patient death, that's a problem.
Refusals are a common occurrence in the EMS industry. Will you share some high points about things that we need to be careful of when we have a patient and we do a refusal? Is it risky? Let me ask you that.
Yeah. Refusals are a high risk area.
Okay.
And it's because patients often don't understand the true risks. And when it comes to a refusal, you really need to have informed consent.
What does that mean, Chris?
Well, informed consent means you gave the patient information,
Okay.
right? You can't have consent without that information.
Okay.
What are they consenting to if they don't really understand the risks and options?
Okay.
So informed consent means we're telling them what potentially could be an issue. We're explaining to them the care that is available if we transport them to a facility. We can't just assume that patients understand what an MRI machine or what a cath lab does.
Okay.
We have to spell that out for them. Say, look, you fell. We can't see inside your head, but an imaging machine, X-ray, MRI, CT, can. If we take you to the hospital, they can see what's going on inside to see if you might have a bleed or something that could result in your death. Get real with them. Tell them, hey, there's real risk, and here's what we can do to prevent it. If they don't have all the pieces of information, really all you're asking for on a refusal document is an autograph.
Right.
And autographs don't get you anywhere. You have to have that informed consent.
So on the refusals that are written, do the providers need to document the conversation in detail, or can they just have the blurb that is written about when you sign this, we're not responsible, and they sign it?
Yeah, that is the autograph sheet I was referring to earlier.
I knew I wanted you to talk about that.
It's not worth the paper it's written on, right?
Can you say that again? Can you please say that again?
You have to document the conversation with the
Okay.
patient. This is what I think is going on, because again, we're not diagnosing.
Right.
We're only able to say what we feel. Here's the potential issues the patient's facing. I'll let them know that this was the issue. Great example: patient in a low-end car wreck, but not wearing a seatbelt, hits the steering wheel fairly hard. No airbag, but there's a bruise. That patient, if they just sign a refusal, great. That's a nice autograph. Let's hope they become a celebrity at some point. Then we'll have something that's got some value. But otherwise, they haven't been told about, hey, that you could have a potential, fractured rib. That rib could be poking into something that's really vital to your existence. You could have a ruptured diaphragm. You can have issues that aren't apparent, but it's clear from your condition, from the bruising, that you took a pretty good hit to your chest. If we explain all that, and the patient says, okay, yeah, I get that. I get that you told me about this x-ray thing that they can go and look inside. I understand that you can't do that here, but they can at the facility, but I still don't want to go. Then you've got informed consent and a valid refusal.
Tell us about the witnesses, Chris. Who can we get to witness that is going to stand? Is it the mother? Is it the brother? Is it the sister or the friend that's in the car? Or should we get, our supervisors involved, or our partner involved, or the firefighter that's on the scene with us?
If you're in one of those situations where you know good and well you would accept transport, then getting medical control involved,
okay,
to just kind of cover and to make it more real to the patient, right? To make it have some gravity,
okay,
I think is a good idea.
okay.
But otherwise, if the patient is in a situation that a refusal you think is reasonable,
Yeah.
Witnesses help if there's a dispute, but usually the patient won't dispute that they signed the release. The only thing they might dispute is their ability to really comprehend at the time.
Yeah.
So did they have the mental capacity
Okay.
to sign? And that's a tough one because that's really subjective. Crew members, I think, are probably more able to assess that than a layperson.
Okay.
So for me, I wouldn't have a problem with the both EMS crew members
Okay.
signing that they witnessed the patient, that the information was given, and that the patient seemed to understand, had an opportunity to ask questions. I think that's vital to document as part of the refusal process.
Okay. One of the things that comes to my mind, we've been doing this a long time, and the reality is, some providers will try to, they walk in with the intent of they already know they're
Yeah.
going to do a refusal, and will influence the patient in not going to hospital or talk them out.
Yeah.
Talk them out of going. What's your thoughts on that? If you get the 911 call.
Yeah, that's unfortunate, and attorneys are onto that. If it's near the end of your shift and you're getting a refusal, guess what? That's going to be looked at harder because they know that you're motivated to not take that one more transport, especially with a low acuity patient that you may think you're going to get stuck on the hospital wall for an hour and be held over. They know there's a motivation for you to not want to transport the patient, and that makes it even more high risk. With those situations, be cautious. In Arizona, they've had such an issue with patient refusals, almost becoming systemic, with crews just not wanting to do the work, that the state legislature stepped in and enacted a law that says crew members cannot get a patient to refuse unless they refer them to other services and have some other healthcare or quasi-healthcare type service basically take over the care of the patient. And you know what? When you've got those type of social services, and because sometimes it is something that EMS in a hospital setting can't really fix, but other social services can,
Okay.
referring over to somebody else is different than just an outright refusal, right? So I think I hope that Tennessee never gets to the point that the legislature has to step in and tell us how to do our job. That's never what you want.
Yeah.
But our policies and our practices certainly should help us avoid that result, right? We should be able to self-police and do the right thing without being micromanaged by the regulators.
Would you encourage all services to do an audit on all of their refusals?
I think auditing refusals as a regular practice is a great idea. Don't know that you have to do 100%, but on the other hand, you probably shouldn't have so many that doing 100% is a lot, right?
Yeah, right.
So, 100% of 10 is just 10.
Yeah.
So,
Sure. Okay.
yeah.
So, Chris, today you also presented on another topic, MIH. What is that? What does it stand for?
Yeah, mobile integrated healthcare. It's used often kind of interchangeably with community paramedicine.
Okay.
The key component difference between the two being that with MIH you can use different types of clinicians, nurses, pharmacists, physician's assistants, social workers, psychologists. There's a lot of folks that get involved with basically meeting the patient where they are, going to the patient. So it's in-home care, in-home kind of assessment of the patient prior to them needing more immediate acute care, with the goal to keep folks healthy.
Are you seeing that in a lot of states?
I think MIH is growing and growing fast. I sit on the board of directors for the National Association of Mobile Integrated Healthcare Providers, and we have members now, I think, in 48 states. So that kind of shows the interest is pretty much universal. And with hospital overcrowding, with hospital patient offload delay times, and let's face it, those are the lower acuity patients. It's time to take a look at how do we keep these lower acuity patients out of the hospital? How do we get them to the services that they actually need? How do we change behaviors and get people away from using 911 and the ER as their primary care physician, right? Why are you calling 911 today? Well, because it's time for my prescription to be refilled. That's not what we're here for. But until we change some attitudes and some, educate some folks to what really are the appropriate resources that they should be using, then we're going to continue to see misuse of the 911 system. And that results in delays for the people that really need treatment. It results in those hospital wall times where crews in some states are sitting with patients, basically babysitting them for 6, 7, 8 hours in a hospital setting. How do you stop that? Well, we move folks into different types of resources, and we meet the needs of the patients in a new way. And mobile integrated healthcare is focused on doing that, going out, meeting the patient in their home where they're more comfortable, doing medication reconciliation, taking basic vitals, looking at the safety of a home, looking at food insecurities and getting folks set up with food banks or Meals on Wheels, those types of social services that aren't really truly healthcare services, but are what the patients really need in order to keep them out of the emergency room. So MIH is, it's growing, to answer your question, but it's an absolute necessity in just a change of mindset in how we deliver healthcare.
Such a needed service. We're so glad that you joined us today to talk about two very, very important topics. And Chris, thanks for what you do. You added a lot of value to everyone that's listening to this today.
I appreciate it. It's fun being here.
Thank you.
Thanks.
Matt, welcome to the podcast. Thanks for joining us.
Thank you. It's an honor to be here.
Tell us a little bit about you.
Oh, gosh. EMS 45 years, still a field provider, still love working on an ambulance, do it periodically. Been in EMS leadership most of my career. Currently, I'm an EMS and mobile health care consultant for PWW Advisory Group, but spent the last 16 years at MedStar, the public utility model in Fort Worth, doing MIH stuff.
So today, we're going to talk about the train wreck.
The dumpster fire.
Dumpster fire and train wreck. All right. So you're here presenting.
I am.
You just came out. We were able to get you here on the podcast, but what's the topic you're talking about, and why is it important?
The main topic is the transformation of EMS. You know, for too long, we have been considered a method of transport. we're paid that way. That's what we do. We respond in ambulance to calls, and we schlep people to the hospital. But that economic model is very challenging, and it kind of is a dumpster fire. With all of the changes in costs and personnel and staffing and the different things that we can do now, that transformation away from just being a you call, we haul type of service to being a, if you need help, we'll come help you. Sort of the all hazards approach, if you will, to EMS delivery. There's no such thing as an inappropriate 911 call. We will never be able to train everybody when it's appropriate to call. But there is such a thing as an inappropriate response to that call. So the person who calls with a small laceration on their forearm doesn't need a fire truck, doesn't need an ambulance. They might need a single unit response to do some cleaning and dressing and maybe get them to an urgent care for suturing, whatever. But economically, we can't do that, because if we do that, we're not getting reimbursed for the ambulance transport.
Right.
So how do we convince our communities? How do we convince the payers? How do we convince the federal government that EMS is healthcare? And we need to be trained as healthcare practitioners. We need to be paid as healthcare practitioners. This is primarily an education conference. There's a big debate going on about degree requirements and about federal designation for paramedics. All of that is great, and we should do that. Only if we don't accelerate the demise of EMS systems by requiring them to spend a ton of money that they're not going to get reimbursed for. But if we can convince TennCare, if we can convince Medicare or other places to pay us to navigate patients, to pay us to give advice over the 911 call and do telemedicine from the 911 center and get that patient referred to their own doctor and reimburse us for that, now we can do all sorts of things that advances the profession.
Are you successful in doing that?
At MedStar, we were very successful. I was explaining in the last session that, and I still work there part-time. So we have a very robust mobile integrated healthcare program with 10, 15 FTEs that makes more money than the 911 ambulance side.
Okay.
And we've been able to convince payers to pay for those services because it's in their interest, it's in their members' interests to prevent the 911 call.
Okay.
Nationally, we've made great strides with getting bills introduced in Congress that changes the basic EMS economic model away from payment for the transport to payment for the response.
That's
so
key,
now
right?
we can do all of the things that field practitioners know they should do. They've got that twisted ankle. There's really no reason to go to the ER. You can go somewhere else. But the systems aren't set up to do that. People aren't trained to do that. They don't have the infrastructure to do that. Well, that change in payment policy will allow a change in practice.
That is powerful. Is that one of the obstacles here, or in Tennessee, or is it unique? Is it across the country? I know it.
It's across the country. Tennessee is actually a little bit more advanced because your TennCare program pays for treatment in place.
Okay.
Some states are doing that. Texas has done it. Other states have done it for a Medicaid population because they've done the back of the napkin math and said, holy crap, every time somebody doesn't go to the ER, we save, $1,000, $1,500, whatever. But in Tennessee, the decision to not transport someone from a 911 call has to be made by a qualified healthcare practitioner, a QHP, which means an NP, PA, or a physician. That's a problem because those are expensive and they don't want to work in EMS, and telemedicine is expensive. Some states, like Texas, you can get paid for the treat and refer, and you don't have to have a qualified healthcare practitioner make that decision. It could be protocolized with some training for the field practitioners that say, yeah, you know what, that splinter in your finger really doesn't need to go to the ER. Let's try and get that out for you and we'll leave you here.
Wow.
So it's starting to happen.
What can we do as providers to kind of move this needle?
Advocacy.
Okay.
You really need to work with your state association. You need to work with the national associations to engage. Like I said, I've been in EMS for 45 years, and I have never seen the interest from Congress, from state legislatures in EMS. We earned that right during the pandemic, but we've also educated our states, our local communities, the federal government, that EMS is the Swiss Army knife of healthcare. And there are so many things that we can do that have nothing to do with transporting someone to an emergency department, and that's how we should be reimbursed. So having the engaged providers talk to their local elected officials, talk to the city manager, the county administrator, that, your budget should fund a community paramedic program. Your budget should fund a treat no transport program, because we're going to keep ambulances in service longer. I was just talking with one of your providers, and you've got in a certain community, I won't mention it, very long delays with ambulances at ERs.
Yes.
Okay, imagine if you didn't have to take everybody to the ER. If your average cycle time in an ER is an hour or 2 hours, and you can treat someone at home and refer them to their doctor, you just gave 2 hours back to the local community at no cost.
Right.
That's how we need to be thinking.
Wow. So, Matt, you just informed us that you're going to be interviewed by national media this afternoon. Tell us about that.
Yeah, so the EMS crisis has gotten a lot of attention in states, federal government, but also the media. I'm part of a group that tracks national media, and there have been over 2,000 local and national media reports about the failure of EMS across the country since January of 21. NBC Nightly News reached out yesterday and said, hey, can we talk to you about the EMS crisis and what's causing it? And, why can't agencies get enough staff? Why are they running out of money? Why aren't volunteer systems able to sustain themselves anymore? So that interview will occur this afternoon. Not sure when it'll actually show up on Nightly News with Lester Holt, but the fact that they even want to do this story is compelling, because thanks to your listeners, thanks to every EMT, every paramedic, every 911 dispatcher out there raising this issue, the only thing that's going to change it is if there's enough education in the community that says, hey, we can't do this for free anymore. We can't do it for 1% of the budget, whatever. We need sustainable funding to deliver reliable service. And then the flip side, we also need to be a little realistic. Having an ambulance in front of an address in 8 minutes with 90% reliability is only necessary on like 5% of our call volume.
Okay.
And if we're going to ask communities to invest in a robust EMS system, we need to redesign the systems based on evidence that shows, that arm lack, that twisted ankle, same-day service would be fine, but certainly get there within the hour. But certainly doesn't need an 8-minute response time, because they're going to go to the ER and sit in the waiting room for 6 hours.
Right.
So why don't we look at the funding that is commensurate with what we really need to do, which is get to the heart attacks and the cardiac arrests and the not breathing calls in 8 minutes. And for the majority of calls, an hour ETA is okay. We just got to change some expectations and break some eggs.
Well, we look forward to listening to that interview, Matt.
Thank you.
We appreciate you spending time with us. Your work is impacting the field nationally, and we're grateful that you're on our side.
Well, I'm grateful for this opportunity. Thank you.
Have a great day.
You too.
Thank you for joining us today on this episode. Please don't forget to follow us and subscribe to our YouTube channel. Also, remember, the most important person you will ever lead is you. We will look forward to seeing you again very soon.